Hi, I'm Dr. Mariam George, and I'm here to talk a little bit about what palliative care means as a specialty, who you would refer to the palliative care team, when to refer, what the role is of the specialist palliative care professional, and a general approach to the management of patients under the care of palliative care. So the definition from WHO, the World Health Organization of Palliative Care, is about improving quality of life of patients and their families facing the problems associated with life-threatening illness. And these problems could be across the breadth of physical, psychological, emotional, and spiritual aspects of life. The key role of palliative care is to enable early identification, a proper assessment and treatment of symptoms and other problems. The purpose of the specialty is actually to enable the best quality of life when time is short. Identifying patients that need our help would be enabled through the use of the Supportive and Palliative Care Indicators tool, or the SPICT tool. This enlists the general conditions of deterioration for patients who may be frail, and it also lists both malignant and non-malignant conditions that would be associated with problems as time goes on. We all know that cancer patients will benefit from the support of palliative care. There are other conditions such as chronic lung disorders, COPD, interstitial fibrosis, heart failure, renal failure, liver failure, and neurological conditions such as motor neuron disease, Parkinson's disease, etc. The SPICT tool provides a list of specific stages within these conditions where you may wish to think about referring to palliative care. But more importantly, what the tool prompts us to do is to think about concerns that these patients may have through those stages that would need specific assessment and help. So, in a sense, the tool is there to help us identify those needs, assess those needs, and plan care for them accordingly. If you were to think about when to refer the patient to palliative care team, the most important thing to remember is that it's a needs-based referral. Definitely, you wouldn't refer somebody with a curable disease. You would think about those who are going through a life-limiting illness. In addition to that, what you must look out for is, do they have a problem that cannot be managed with the general medical care that's being provided? And it may happen at the time of diagnosis, it may happen a bit further on. Or it may be that they are dying and they have complex needs that cannot be managed by their usual team. In a sense, it doesn't matter if the patient's just had a diagnosis and they're still having some what you would call palliative chemotherapy or palliative treatment, and they're up and about. Very often people misunderstand the word palliative care for end-of-life care. It's important to understand the meaning of individual words, because in the community, if we look at our doctors in general practices, the word end of life would indicate anybody who could be in the last 12 months of their life. This would include those who are in the last days or weeks of life, but it does not mean that that's just it. Therefore, if you look at this bubble, the Venn diagram, you would see that there's a big spectrum, and care of the dying forms only a tiny part of what you would classify as palliative care. The key message again is about providing a total, active, holistic care for these patients, irrespective of where they are in their disease trajectory. I'd like to share Kat's story. She was referred to us shortly after being diagnosed with motor neuron disease at the age of 68. She had bulbar variant of the illness, which meant that she had difficulty swallowing and she had difficulties communicating. She had issues with accumulating secretions, some pain in her muscles, all of which were assessed and addressed. She also had, unfortunately, frequent admissions to hospital as a result of the feeding tube falling out intermittently. The key message that I'd like to share about Kath is the fact that she was referred to as early on, and she was looked after by a multidisciplinary team through the course of her illness, which was around 12 to 18 months. And the palliative care team supported her when she was in hospital, as well as at home, but also when she was admitted to the hospice for a brief spell in between. From a holistic view, the important thing to know is that a person going through a life-threatening illness has 4 facets that will be affected: their physical state, the psychological or emotional state, their spiritual well-being, as well as their social background. Obviously, it is understood that illness will impact on the physical state of one's being. The role of our specialty is to identify those concerns, symptoms that may arise, and try and alleviate those to minimize suffering. That's a given. The other aspects of one's life that we have to focus on are the emotional well-being, because the way that they cope with the illness has a massive impact on their quality of life. Therefore, it's important to have a psychological assessment of how they're doing, what anxieties they may have, what concerns they may have, and how it may be impacting on their day-to-day life. It is recognized that psychological state enhances or diminishes their physical experience as well. For instance, one who is always anxious will feel more pain than the other who does not feel so anxious. From a spiritual side of things, very often there's a misunderstanding that spirituality equates religion. Spirituality entails what does life mean to them, and how do they perceive the experience of living, what's important to them. For some people, it is family that makes up their spiritual state of being with their loved ones. For some people, faith can actually cause more distress than provide them with reassurance. That's why it's important to explore what life means to them and what experience makes a difference to them. The social background is relevant, particularly in situations where people may have concerns around their financial state of affairs, if they have young families that they're worried about, or it may be as simple as, we don't have anybody to look after us. What kind of package of care will we get? We live in a council flat. What will happen to us if we can't pay the bills? And the list goes on. So it's really important that we look into each element of those 4 domains and listen to their concerns and try and do our best to alleviate them. Sometimes the role may well be in just signposting them to the right places. For example, with social concerns, they say they haven't sorted their affairs. You recommend that they go to a solicitor to organise their will, if that would help them. So the key message is that as a palliative care professional, we have to take into consideration all those 4 domains. Returning to Kath, as time went on, it was a bit of a dilemma as to how to support Kath so that she didn't have to keep coming into hospital. We knew that she did not enjoy being in hospital, and therefore it was a bit of a bafflement as to why she kept coming back in. We arranged for a specific meeting to talk to her to help identify what her main worries were. She was very honest, and she said she actually wanted to die and she didn't want to have her suffering prolonged. However, from a spiritual perspective, her faith actually took precedence in the fact that not going into hospital, to her mind, meant that she was actively committing suicide by declining any kind of intervention that would keep her going. And for her, that was not acceptable. So therefore, her spiritual belief took precedence over her personal wishes to minimize her own suffering. Subsequently, we reassured her that her wishes would be respected, and therefore, as a team, we made it quite clear that for Kath it was important that even if the tube fell out, we would attempt to bring her back into hospital and attempt to put the tube back in, with the understanding that actually this may well mean that she died in hospital rather than in her own environment. Eventually, that is what happened. But as far as Kath was concerned, that was okay. And the advantage that Kath had was that she had a team that knew what she wanted and did everything possible to make that happen. The specialist palliative professional's role, or rather roles, are quite varied. Of course, as doctors, the clinical side of things really matters. You're there to provide them with the best clinical management possible, assessing their symptoms, understanding what kind of medical interventions may be helpful for them, and perhaps even working side by side with other specialists to get the best care possible for them from a medical management. Another key role that the palliative care professional has, and this is not just the doctor but all the nurses and all the wider multidisciplinary team that are involved within the team, would be as communicators. They are skilled to hold sensitive conversations and often get to the bottom of concerns that may not come to light until and unless you make it a point to ask about them. One of my roles is also being a negotiator, and this could be between patient and family, or it could be between healthcare professionals. The purpose, again, is to make sure that the patient's concerns are identified and addressed as best possible, with as many people being involved in the right manner. We often find ourselves coordinating care for patients. For example, if a patient is in hospital and is seeking to get home, we make sure that we contact the right teams involved to facilitate a quick transfer to their preferred place of setting. It may be home, it may be hospice. And because time is short, it's all the more important to make sure that all of those steps are carried out in a quick and efficient manner. Last but not the least, because palliative care is so important, our key role is to raise awareness and provide education to wider staff about how they can provide generalist palliative care to the patients who are with them. And this may involve providing specific training programs, or this might involve informal teaching opportunities. When I go and see a patient, my first thoughts as I prepare, looking through their medical records, is having an idea, an understanding of what to expect when I get to their bedside. And this would help with my assessment and management plan. Some of the key points to think about is what could be their physical state. What kind of abnormal physiology would they have? Are they extremely thin or cachexic? Do they have organ failure? What kind of comorbidities do they have? Do they have multiple problems that might all contribute to each other and to their general state of being? What kind of drug interactions should I worry about? Do they have multiple drugs? Is there polypharmacy? Are they able to take their tablets? Can they swallow it? And if they can, are they feeling sick when they take it? And last but not the least, for each individual, what's their priority? Do they want everything done for them so that they can keep going, even if it may be at the cost of being bedbound for weeks? What's their balance between quality of life and survival? So, as I go to see a patient, all of those thoughts come to mind. And the other thing that I need to know is where there could be in their disease trajectory, in the journey of their disease, Could they be at the early stages when they've just been diagnosed? And has their diagnosis happened late into their disease or early in their disease? So for instance, we know that when a person has cancer, as long as they're on treatment, well enough to have treatment, they have a decent chance of survival for a certain period of time. Once their cancer treatment has been stopped, either because of their own choice or because they're too poorly to have it anymore, we know that once that treatment is stopped, their deterioration is likely to be a lot more rapid, so that decline will happen fairly quickly. That's not so much the case with certain conditions such as organ failure. For example, the average patient with COPD will have a gradual downward decline with intermittent periods of exacerbation, which might lead them to coming into hospital. So they come into hospital, they get their infective exacerbation of COPD treated, they recover a little bit, and they then get discharged, but they may not get back to their previous baseline, and they continue to remain on that downward trend. Heart failure patients are quite similar in that manner. They come in for an acute intervention, they get a bit better, and they go back. It's harder for such patients to comprehend the possibility of death happening soon. Therefore, the way we communicate those discussions would need to be tailored accordingly. In cases such as frailty and dementia, it's harder to prognosticate. It's harder to tell when exactly they might be approaching dying. So it's just for us to understand that we're never experts in saying exactly when things will go wrong. However, the closer people get to the end, the better we are at prognosticating. And again, why is that important? We know that if somebody still is up and about and is looking to having quality time, we know that it's appropriate to request CT scans or investigations that will help us manage the reversible causes and help them have the best out of their time. If somebody's bedbound and looks like they've been bedbound for some time, you really have to weigh up whether investigations are really going to make a difference to them. That's why it's important to know where they may be in their disease journey. So, in summary, if you were to ask me, what is palliative care as a specialty? I will say that it is a unique, clever specialty that uses a holistic overview to optimize quality of life for anyone with a life-threatening illness. And for that, we utilize our clinical skills, our communication skills, and multidisciplinary working. Because at the end of it all, we will not be able to do the best for a person without working closely with the wider team. Thank you.